Oh, hey, Chris.
Hey Chuck, how are you?
It's a special day. I'm great.
It is a special day. Is it because we have a guest?
It is absolutely because we have guests, but not just any guest.
We have a guest that is very special to me. Megan Conti Mica is joining us for this episode, and well, we should talk about Megan in a little bit. Megan is probably one of my favorite collaborators outside of Chuck.
That's saying something. Chris likes to collaborate, as I think we all know. He collaborates in research, collaborates with people who like to talk about food, weirdly enough. He collaborates in all kinds of things.
Oh, well, before we talk about Megan, I want to talk about her husband, Mike, who when I came there and visited Megan, she was kind enough to let me stay at their place. And Mike made this amazing meal, and I know that Megan can throw down in the kitchen too. It's just a great couple. I mean, the quality of the chicken that I had there was fantastic. And chicken is easy to mess up, and it's hard to make really good.
I was raised on a diet of chicken and rice, so I would have enjoyed that meal. I have no doubt. I have no doubt. Um, Anyways, I think we you should do the as formal an introduction as you're gonna do.
All right. Well, I'm thrilled that we're joined by Megan Conti Mica, who is currently in practice at the University of Chicago, but is going to be moving to Scottsdale for a new gig and a new transition pretty soon. She trained at Loyola and then went on to train at the world famous Mayo Clinic for her hand surgery training. Megan and I have collaborated a lot, and she is a dear friend of mine. Currently we're in a hand travel club together, which has been super fun. But during the height of the pandemic, we were part of one of the Hand Society's initiatives for online education, which was Firsthand, the master class in hand surgery with Peter Stern for about 14 months. We got together every month and got to talk to some really great legends in hand surgery. So Megan, welcome to the pod.
Thanks, everyone. I'm really excited to be here and super honored to have been asked to be here by you two.
You're
Well, I,
probably wondering why it took so long.
No, you guys, invited me about 2 days ago, so I'm more wondering who canceled, and I was, F squad, and that's why I got my invite.
there was a long list of cancellations, but no, you were our first choice. We have a great topic to discuss. A little teaser. We're going to talk about distal radius malunions and just general surgical approaches. But you were honestly both Chris and my first thought. And I think we both have a relationship with you, Chris, obviously with Firsthand and Travel Club, and you and I were lucky enough to travel to Israel to represent the Hand Society with the joint Hand Society and Israeli Hand Society meeting, and that was super fun to meet Mike and meet your youngest and bond with you guys and my son, and it was really great.
That was really fun. I think we definitely uh, convinced your oldest son who's going into medical school to maybe wait on having children after watching us travel around Israel with a 3-month old.
I think that's true, but you guys made it look easy, even though it was not always pretty. You guys made it look easy.
Yeah, I don't know about that, but thank you. And Chris, obviously, always a pleasure to spend any time with you.
It
Um,
is, isn't it?
yeah, yeah, okay. All right, now I regret giving you any type of compliment.
Oh,
Well,
Megan, it's just it's so much fun, and it's always very easy to talk with certain people, especially it's kind of like Chuck and I do this frequently. When we were doing Firsthand, it was just such an easy conversation with you. So thank you for being a partner in crime on that one. Certainly had its share of ups and downs for sure.
It was fun. It was interesting and educational all at once.
what? So
Exactly.
I have two questions. I always like
Of
to ask
course you do.
two
Of course you do.
questions. The first, and I'll ask them both, and then maybe each of you will take one of these. The first one is, why'd they cancel your show? Why'd they pull the plug? And the second is, I want to know more about that travel club because I'm in a travel club is a little different, so I'd love to hear more about the one you two are in.
Well, Megan, why did you get canceled?
I know, right? I got canceled. It was,
I'm still on the air with Chuck.
I know. Actually, we chose to stop recording with Peter Stern retiring. So it just seemed like the right thing to do. It was just a timeline issue for us. But in retrospect, I think we could have gone forever, right, Chris? We could have kept making video after video, podcast after podcast, but I don't know if anyone would listen. So I think at some point, things have run its course, and it's time to move on to bigger and better things, which for Chris was this podcast, and for me it was silence.
I have nothing to add, as you would say. But no, I think it was a good time to transition. In all actuality, we could have gone on forever and interviewed a lot of people, and it would have been super fun and very educational, especially at least for us. But in reality, there was a lot of, I think, fatigue for online webinars after 2 years of the pandemic, and just interest, I think, was starting to flatten for everybody involved. And I think that it was just one of those natural times where, with Peter retiring and stepping down from a national stage, it was the right thing to do. We
It's
talked about
like
having
Seinfeld.
right,
It's like
exactly.
Seinfeld. You gotta retire on top, right? You gotta stop when people are still interested.
And those
Exactly.
royalties, and those royalties.
Yeah. We're in syndication. I mean, it's
Yeah.
great.
Yeah, we're not getting Seinfeld royalties. We, in fact, didn't even get any swag, which we regret. But yeah, I think it was a lot of fun to do, and I encourage anybody who hasn't listened to some of them. There are some just absolute pearls of knowledge that are dropped by a lot of really, really talented surgeons. And for us, it was super fun just because you got to interview some of the living legends of hand surgery. So I think that's an opportunity that I will always have cherished. And about our travel club, we're kind of a small group, but I think for a lot of, I was actually just talking with one of our fellows who's graduating, and I asked him, David Wright, I asked him if his generation of hand surgeons has started to form a travel club yet, because I know there are a couple clubs that have formed even after, Megan and ours group, and it's interesting because at least the way that I've seen it done is that it tends to be people who have kind of done fellowships within a couple of years of each other, and you get together and on a annual basis, and get together when you're all at the Hand Society and whatnot, and have a fun kind of trip. Obviously, there's some business involved, but people bring families, and you try to go somewhere where people want to go, and it's a smaller kind of a casual meeting. We had a lot of fun when we got together. We've done a couple of meetings, and you talk about cases, you talk about the challenging parts of your practice. You can make it whatever you want, make it a research gathering, that kind of thing, if you want to. So everybody kind of contributes what they want to contribute, and I think there's a great bond that's built there. What do you think, Megan?
Yeah, I think it's a very unique thing to hand surgery. My husband's a spine surgeon, and he's super jealous. He keeps talking about doing something in the spine world, but I don't know if we can afford those types of bougie trips.
They probably
But
don't. They probably don't like each other that much either. That's the beauty of hand surgery versus spine surgery.
Yeah, no, I think that I was at the one dinner where Mike picked the wine, and then we were like, wow, this is the level we're rolling at now.
I know. You can't put Mike, food and wine. You got to be very careful with putting him in charge, or you just have to kind of close your eyes and realize it's just going to be the best of the best. But reality is our travel club is. I talk to you guys. I mean, on a monthly basis, there's someone I talk to, and it's for cases, it's for personal advice, career advice. So it becomes, it makes your world a little bit smaller, but also that you feel supported with questions that maybe you don't feel comfortable asking your partners, or you just want somebody else's opinion that does these surgeries more often than you. So, I mean, I've had some disaster cases, and I call up Dave Brogan because I'm like, man, if there's somebody who knows disaster cases, it's this guy. And he's given me sound advice that I've followed, and it's been really, really helpful just to send out, the bats, the bat signal, and see who responds.
I love it. My travel club's a little different. It's just congenital. It's a small international group, and it sort of serves a different purpose. But I think I want to go back to what you said, because it's really important for those younger listeners, is when you start practice, no matter how prepared you are, the things that seem simple in fellowship and residency are no longer simple, and the hard stuff's harder. And I didn't have a travel club when I started practice. I had three really good hand partners, so I would ask each of them questions intermittently. And then you feel like, oh my God, I've asked Marty Boyer too many questions. So then I'd email or call Dr. Stern. And then all of a sudden you're asking too many questions. You're like, everyone thinks I'm an idiot. I need to find someone else to bounce questions off of, which is just the facts of life. And I think your point's a really good one and really helpful to hear.
Yeah, I think,
Yeah,
go ahead, Megan.
no, it's just a lot of the practice management issues as well. Like you run into problems and you ask your senior partners, and they're just at a different level in their career. So when they have to solve problems, it's just a little bit different, like they've been there for 10, 15 years, they've already established a voice, and you're early in your practice and nobody really cares about your voice per se. And so it's learning how to navigate those types of situations, and having somebody else who's just going through the same thing. It's really valuable to have that lateral mentorship as opposed to that up and down, like that superior mentorship.
The one way to gain more mentors, and I've heard this can be really helpful, is just to move your family to a different location, and then you meet new people, and you can ask more questions. Has anyone tried that strategy?
I'm in the midst of trying that strategy. Let me tell you, it's better just to make cold calls. I think that might be easier. But yes, we're in the midst of a move. I've been with the University of Chicago for 8 years. So this is my first move. So I've been really, really lucky that I've had a great run, and haven't had to move practices early in my career. I've really got to stick it out and build roots, but that also makes it harder to move because you have built roots and you have a great practice and you have great patient population and referrals. So it is a little scary, to not only be leaving something that is really good to move somewhere else, but it's a lot. It can be a little complicated, and so I'm really excited about it. We're moving back to Arizona, which is where I'm from. My husband is getting a great gig. I'm getting a great gig. So fingers crossed that, this is a good long-term move for us and for our family.
Yeah, they're lucky to have you there in that practice. And it is obviously a loss for University of Chicago, because you were very involved with their fellowship and residency training and a beloved mentor for them. So they'll miss you. I know you'll keep up with your relationships with them, but for the future trainees at the University of Chicago, it's you won't get the Megan Conti Mica love that everybody else has gotten, and so many people have spoken fondly of.
That's really sweet of you to say, but they all know that I'm always a phone call away, and we're gonna be visiting Chicago all the time because my husband's family's here. So they already know. I've already planned to come back for graduation next year, so they can't get rid of me that quickly.
And I think one more thing before we jump into our clinical topic for today, you're kind of a big deal. You're running the annual meeting for the Hand Society this year with our hand club buddy, Paige Fox. So what's that been like? Chuck's done it before. I hope to not do it anytime soon.
It's actually been an honor. So first of all, I get to do this with Paige Fox, who was my co-fellow at the Mayo Clinic.
I believe it's supposed to be called the world famous Mayo Clinic.
Oh,
That's what David calls it whenever he talks about it.
well, Dave Brogan knows. I mean, I don't even need to say world famous because everybody knows it's world famous. So it's kind of almost redundant, I guess.
WFMC is what I was told.
But I mean, it was a wonderful place to do fellowship. Absolutely, no question about it. But it's been amazing to get to build up that bond again of somebody that I did fellowship with, and we're actually going to be in Toronto, which is one of our other co-fellow, Heather Baltzer. That's her stomping ground. So she's been helping us a lot with locations, restaurants, stuff like that. But it's going to be a great meeting. It's going to be a different meeting because we're not going to be in the United States. We're going to be in Toronto. So please get your passport in order. That is my biggest fear, is that people are going to show up to the airport and then all of a sudden realize they need a passport to go to Canada. But the meeting's going to be great. We've done a lot of different things. There's going to be a lot of different types of debates. We're going to have a lot of different symposias, masters giving lectures and having one-on-one with masters. So it's going to be a lot of new content and a lot of more diversity and voice. It should be really exciting.
It looks great, and I have been through this. It's not easy. It's a lot of time, and you have done this without Angie, so the transition, I'm sure, was a little more challenging, at least. And it's always easier you're a creative thinker, and I'm sure Paige is as well. It's just easier to do what's been done before. To branch out is hard. It's hard to create the content or the concepts. It's hard to get speakers to agree to it. So I think we're all looking forward to it. So congrats in advance, and Passport is good to go.
Yeah, it is hard. But change is always scary. Definitely, we're with a new ASSH group for annual meeting planning, but everybody has stepped up to the challenge, and everyone is making this the greatest meeting. So sorry, Chuck, we have to take that from you, and hopefully the year after us, they do even a better meeting, and that we keep building on each other.
For sure.
I think it's going to be wonderful. You always bring such great energy, and I'm sure the meeting planning committee and the staff are very happy with that. Chuck, we should probably thank our sponsor before we dive into this distal radius malunion topic.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. And I'm sure Megan probably has looked through a lot of practice resources and job searching resources as she's looked at that transition in practice.
It's nice to have something in one place. So take a look.
There you go.
Yeah.
She's plugging PracticeLink too. Look at that.
I'm hoping you'll ask me back one day,
Well, there is a lot of stuff that we should have you on to talk about. I mean, when I think of in all seriousness, I think that you've done a wonderful job with advancing in academics and in reputation, and establishing yourself as a presence both in hand surgery in general, but also a lot of our topics about trying to establish more diverse and inclusive training environments, and you've done fantastic work with that. So I guess we'll have you back.
Yeah.
Oh, well, let's see how the actual content goes before you start promising me anything.
Yeah, let's see how many downloads we get here. No, I think
Oh my gosh, I'm calling my family in. If that's what it's based on downloads, I have a Catholic side of the family and a Jewish side of the family. They will be all over it.
5-star reviews, all commenting on Megan Conti Mica's appearance on the Upper Hand.
Do it.
I'm a little afraid you guys are scheming to boot me off the Upper Hand, which
welcome to First Hand, where Megan and Chris talk about hand surgery.
Good work. No, I think the no-brainer invitation, which you may not feel like doing, would be after the hand study. We usually do a debrief. So maybe if you have the energy and the time post hand society, we could gather and talk about that.
100%. I'm in.
All right. So Chuck, what do you want to talk about today?
Yeah, one topic which I get asked about a lot, and a case that can be delightful, and it's also a case that can be really challenging, is the distal radius malunion. And so there are different ways to approach the classic malunion. So let me paint a picture, and then we can discuss. We want to be a little technical about how we would approach things. So the picture is this. So we have a 60-year-old, very active young lady who has a classic distal radius fracture. She fell while playing pickleball. And
I knew you were going to say pickleball. I actually saw this patient yesterday, I feel.
I've seen this patient. And unfortunately, she is a tough lady and kind of wanted to tough it out. And she bought a splint at Walgreens and put it on. And she comes in to see us 5 weeks later, not in any pain, but with significant deformity. So she had a classic distal radius fracture, metaphyseal Colles type, and she now has 35 degrees of dorsal tilt. The relationship between the radius and the ulna, it seems like the ulna is now long. I personally have a hard time figuring that out when there's so much dorsal tilt. It's an extra-articular fracture. Again, she's not having any pain, but she comes in to see, and maybe Chris, you could start with you. What's your first, you're having the initial conversation with her in the office. She does not have evidence of nerve issues, because I know you're going there. And she just comes in with deformity.
I feel like this is a patient that we all see, and so this is somebody who has automatically self-selected to attempt at non-operative treatment, because sometimes this is the other way that this kind of scenario comes up, is that you try something and they slip into dorsal angulation. Sounds like based on the patient profile, that this is somebody who I would think about, fixing if they had come early on anyway, fixing with surgery, so we could start some earlier rehab. So I think the conversation is more about, what are you looking for in terms of, return to activity. I think it sounds like they want to get back quickly. I do have the conversation about the appearance of the deformity, not necessarily only for aesthetic reasons, but I've found that comes up. And I think it's important to be proactive about, saying it's going to always look like this. There's always going to be that bump on the pinky side if we don't do something about this. Are you okay with that? But I think there's, pretty strong consensus in the literature that, leaving somebody at this age with this desired activity level with that amount of dorsal angulation is going to have negative implications on their functional outcomes, particularly grip strength, and kind of activities of daily living. So it is a discussion about, we got to break your bone again and put it back in place and get you going. Megan, what are your thoughts?
Yeah, I think it's a long discussion because it's tricky because they're not symptomatic right now, in the sense of pain. But the question is pronation, supination. Are they having that block of rotation? And that's where these malunions can cause a lot of issues. And so if she is, this is her thing that's keeping her mentally active, physically active, is pickleball, and she's not able to move the racket. In all seriousness, that's something to discuss. Yeah, maybe she needs some physical therapy or occupational therapy to get her back. Or if this is something surgically we need to fix because there's a bony block. I think the long-term conversation is there is complications with surgery. This is not a slam dunk surgery. And when you lay everything out to the patient, they have to make a decision. Ultimately, this has to be a shared decision-making situation because one, there is a lot of opportunity for this not to go exactly the way they want. And they have to understand that the risk is not really going to be exactly how it was before the fracture.
Now, Megan, Chuck and I end up getting in a little bit of an echo chamber just because of the podcast and then also because of our, conference interactions and stuff. I mean, what are the complications you talk about with this kind of patient or a distal radius patient who's coming in for an acute fracture and you're talking about surgery versus, non-operative treatment?
Yeah, I have seen a lot of complications in my practice so far. And so it's been pretty humbling. So I don't just see fracture, fix fracture, or see x-ray of malunion, fix malunion, because I've seen what happens afterwards. And it can be pretty devastating. I've actually had non-unions happen. And it's not fun to have a non-union of this because it was hard the first time you did that corrective osteotomy. It's even harder the second time. So, tendon injuries, especially if you're doing a opening wedge osteotomy, that EPL, it can be definitely injured. It depends if you're going dorsal or volar, so the plate placement. I personally always go volar because I am post volar plate invention, and so I feel more comfortable going volar. So patient health, like pathology, their biology, if they're going to heal this thing. And then also their range of motion afterwards. A lot of times these patients, they go and they're in a cast and they may or may not be doing early range of motion, and then they have a lot of stiffness. And they came with you with stiffness, and now they have a different type of stiffness that can always be frustrating. So infection, I mean, I can keep going.
So awesome. I have a lot I want to unpack from what was said. So first of all, I think your point about rotation is really important. And sometimes, if we call 80 and 80 degrees of pronation, 80 degrees of supination normal, it's not always terrible rotation, but it's just not what they had before. And for some patients that matters, at least in my experience. For some patients it doesn't. It mattered for this lady. So that's a great point. And then when we think about the appearance, I think about it in three buckets. Chris mentioned the prominence of the ulna. The distal ulna, that's certainly an issue. The actual deformity of the radius is an issue. And the third one, which can be a little tricky to figure out clinically, but is more apparent radiographically, is the loss of radial inclination. And in the classic fracture, that's a big deal, maybe in this one too. And we can talk about it for corrective purposes, because if you lose that radial inclination, as I think we all appreciate, that the risk just tilts over. And it's not a functional issue at all, but it is a big appearance issue. So my
Yeah,
question,
they hate that zigzag deformity.
they hate it. They hate it. So my question to you both, because I think you guys are in a different generation, and I think it was a dig to say I was in the post volar plate era. I was in the pre volar plate era, barely.
When dinosaurs roamed the earth.
That's right. My
Chuck trained in
question.
the 1890s. He wanted me to be very clear on the last podcast.
My question is this. um, in all seriousness, in my residency and fellowship, we talked a lot about adaptive midcarpal instability. I don't feel like we talk about that anymore. And so and I'd love both of your opinions, but to quickly define it, this is a situation which would allegedly cause adaptive midcarpal instability, a lot of dorsal tilt, and you lose wrist flexion. And so the theory from Fernandez was you would, quote, break in the midcarpal joint and you'd get extra flexion in the midcarpal joint, your lunate would go dorsal. And I just don't know that people talk about that anymore. Am I right or am I wrong?
You are right. And I think the reason why we don't talk about it is we're trying to avoid it, because I don't think we have a great solution for it, especially if you have an older malunion, because that's when that happens. There's usually two types of midcarpal involvement. One is that, as you were talking about, the adaptive midcarpal dorsal instability, but the other one that we don't talk about is just that subluxation. And I think the subluxation is easier to fix with the osteotomy, but the studies haven't supported that the osteotomy is actually going to fix that malalignment. And that's something to think about. And that comes back to that whole thing. Your wrist is not going to be the same after your surgery.
Well, I think, you getting in there, I mean, 5 weeks is much better than 6 months, in terms of, the development of that adaptive midcarpal instability. I mean, I remember reading about that when I was in training and, but not ever really seeing it in practice. And again, maybe it's seen me, but I haven't seen it, so to say.
Yeah, it's super interesting because when you have that dorsal tilt, sometimes the lunate goes with the distal radius and sometimes it doesn't. But you're both right. And in this case, it's not a discussion point because it does happen over time. And so at 5 weeks, we're not too worried. All right, let's jump in, if it's okay, to some technical. So Megan, you're going to go volar. Chris, are you going
Yes.
volar?
No, I'm going dorsal. It's
Love
way
it.
easier.
What?
It's way
Oh my
easier.
goodness. All right.
Some
Let's
of
bring
some
out
of
the
us
boxing gloves.
have learned different techniques other than just volar plating, Dr.
Oh my
Conti
gosh,
Mica.
you're poor. I know that you're only worried about nerves, but there are tendons back there.
I
You gotta
know,
be,
and
you have bought them a secondary surgery of
you
having to
know,
take that plate out afterwards.
I would argue that sometimes the volar plate's a little not nice to the flexor tendons too, in what we've seen.
Well, you're actually you're that's a really good point. Especially when you have these dorsal angulation malunions, which are the more common ones, right? It's not
Mhm.
usually the volar angulation. And that prominence when you do the osteotomy can make those fixed angles not fit, fixed angle plates not fit correctly. So that is a very valuable point. But I'm really strong and I can bend those plates and I can do osteotectomy. So I'm able to make those plates fit.
I mean, I like the volar plate. I think a lot of people will use it as a reduction aid. I think that is a really nice technique, and I've done it. And I think that if you're going to use it as a reduction aid, and get the plate exactly where you want it, or you have to bend it, like you're saying, with your very strong hands.
That's just a an online dig on you, Chris.
Right,
That was all it
exactly.
was.
Well, if you have to, I think before you use the plate as an aid, you really got to make sure that you're completely released on the dorsal side. So when I go volar, I end up making a dorsal counter incision for two reasons. One is to make sure that you're completely, released on the dorsal side, and then the second is to look for those extensor tendons to make sure you're not going to bugger them up, particularly the EPL, because in a malunion situation, the anatomy I think is somewhat a little distorted. And I'm probably in the minority. I saw Chuck grimacing as I talked about a dorsal counter incision, which is why I would just go dorsal.
All right.
So wait, I'm excited to see what Chuck has to say because I'm feeling that we both do the same thing. All right.
Of course you do.
I'm
You're
sure we
sportsy.
do. I'm sure we do. So I think we've already heard two really important technical pearls. And I think, Megan, yours is really, really important. And I don't think I realized it for years. So if you're going to go volar and you're going to use the volar plates, which are all pre-contoured, and if you don't restore volar tilt and you just accept neutral, and I'll be honest, I accept neutral all the time, then you are setting yourself up for problems later because your plate's going to be prominent. So super important that you either restore volar tilt or contour the plate. So I love that point. And Chris's point is also good. You don't always have to make a dorsal counter incision, but you have to be aware of the tendons. And you have to keep them safe if you go volar. So love those. So two pearls already. So Chris, since you're clearly in the minority, why don't you briefly walk us through how you approach this dorsally?
Right. So I usually end up taking the dorsal position here when we're in conference because everybody else except for Marty wants to go volar. So honestly, if you could go, I've done it both ways, and I think that both will work. I like going dorsal just for the reasons that I stated in terms of avoiding knowing exactly where I'm released, but then you come into the same issue of making sure that you're completely released volarly. I think you can kind of peek around from the radial side and make sure all your bone is released through your approach. I think that the concern for the tendons is not as big as as it was when you were using dorsal plates that were like tendon shredders. I think the plates are better contoured now, and have smoother edges, and as long as your screws are sitting flush in. And I'll be honest with you, I think it's dealing with an extensor tendon issue tends to be a little bit easier than dealing with a flexor tendon issue down the line. And I have not found the dorsal plates to be as prominent and bothersome as others have described. So I can't honestly remember taking out a dorsal plate, knock on wood, but have taken out volar plates that both I have put in and then others have put in, a number of times over the years. So, in terms of doing the approach, it's a pretty simple approach, pretty straightforward. Starting, transpose your EPL, identify, move it, go between 2 and 4. And then really identify, your fracture plane, just like any sort of corrective osteotomy. Localize it on fluoro. I tend to use, depending on the case, I'll either use a saw or just an osteotome. And I think your point about trying to restore the right amount of volar tilt is good. And even if you're not using a volar plate, I do try to go for volar tilt rather than just neutral.
So in this case, Chris, do you use the plate as a reduction tool? But we're only 5 weeks out. Hopefully the reduction is not that hard to get. Are you creating your opening wedge and then just maintaining it and putting your plate on? Do you use bone graft? Those two questions I think would be helpful to hear.
So I don't think you need to use bone graft. There's a number of papers out there demonstrating that you don't have to. I actually like the tip that my hand club partner and our actual WashU partner, David Brogan, does. After I do the wedge, I usually use some of those cancellous chips or croutons to help kind of provisionally hold it in place as a wedge. Knowing that it's not structural truly, but it's going to help me kind of see where I want things to line up. I tend to use a provisional K-wire to really help hold my reduction kind of from the styloid towards the metaphysis, and really get the tilt just right. I tend not to use any pre-contoured dorsal plates, to be honest with you. The system that I'd used before, I found the plates to be rather chunky. So I end up using a mini frag plate and usually like a T-type plate, and honestly manually with my strong hands, bending the plate to dial in exactly where I want it.
Megan, any questions for Chris before we pivot to your description of a volar approach?
Yeah, I think we've kind of clumped all of the distal radius malunions together. Do you change your approach when it's volar versus dorsal angulation?
Yeah, I think so. I mean, I honestly it would depend on the deformity, and you're right, we're clumping it all together. So to be very clear, this is a dorsally angulated fracture with dorsal displacement of the distal piece. There is no intra-articular involvement, at least of the malunion component. So we're not trying to equate everything together. But yeah, I think I would. I think that this one's easier because I go dorsal because that's where the deformity is.
Yeah, I just the other question I have for you is, what do you do with the ulnar for the ulnar side? If obviously if there's still length issues, or at which this patient I believe had a length issue with possible the starting of carpal abutment.
Well, I think that, as Chuck mentioned earlier, I think it's really key to get your length and inclination right. And I think that getting the radius out to length, in this particular situation at 5 weeks, I'm not expecting it to be very challenging to get the radius out to length. And I think that is honestly easier from the dorsal side. And since I tend to use, an osteotome as a reduction tool to just kind of tease up that radial side and then pin it or wedge it exactly where I want it. I get it. I'm kind of OCD about this, but I get it exactly where I want it, and then I put the plate around it as opposed to using a plate as a reduction aid because I'm going from dorsal. Chuck, what are your thoughts? I mean, I know that we've got to wrap up soon, so.
Well, we got a few minutes, I think. The great points on going dorsal. When I go dorsal, I like the crouton tip just as a temporary reduction aid, or you can use K wires. K wires are a little cheaper. And we should be going for anatomical restoration of the distal radius, and hopefully that obviates the issue with the distal ulna. I don't love doing a distal radius osteotomy with an ulnar shortening osteotomy, but I think we have to be honest with ourselves. In a different situation, longer standing, it may be harder to restore the anatomy, and you should go ahead and do the ulnar shortening if there's any doubt, right? Sometimes we get ourselves in trouble saying it'll probably be fine, or we can always come back and do another surgery. If you think it's going to be an issue and you can't really restore the length of the radius, then you should shorten the ulna.
Do you consent for possible ulnar shortening osteotomy when you have a spidey sense that it's going to be challenging?
I do. I still try not to do it, but I do. And the other thing, if you truly are lengthening things, let's say it's a 2 years out and the ulna seems really long, I hate to bring nerves back in the picture, but in that case, I always do a carpal tunnel. I don't think in this patient 5 weeks out, I would necessarily do a carpal tunnel release. Megan, what about you?
Well, I think you have to take a step back of going dorsal versus volar. So the dorsal you're doing an opening wedge osteotomy, whereas if you go volar, you probably going to be doing a closed wedge osteotomy, which decreases your length, and you probably are going to have to do something with the ulna. So then, so I just, before I even answer the carpal tunnel question, I do think that's important to point out is that at the end of your procedure, you really have to look at that length and see what you have and have not obtained and make a decision from there what you need to do with the ulna. I mean, if less is always more, but if you do a distal ulna resection, you can always use that, or even if you do an ulnar shortening osteotomy, you can use that as bone graft so that you can not use those bone chips and save a little bit of money. We don't have the fancy WashU money on the south side of Chicago, but there's other ways of using that bone and not just throwing it away. But then when you get
Just
to the
like
carpal tunnel,
it's like you talk to the spine surgeon, local bone graft.
but the other part of it is the carpal tunnel. I don't think you ever lose anything by doing a carpal tunnel release. So if you it runs through your head, I should do a carpal tunnel release, just do it. It's like doing fasciotomies. You're never going to feel bad about doing it. You're going to always feel like, well, we saved ourselves from something worse. So I usually talk to the patients about it, and but it doesn't necessarily mean I'm going to do it, but it's there.
Especially if you're at a place where they're very efficient about preoperative blocks, then there's no way to know after they've done the preoperative block about whether there are carpal tunnel symptoms. So I agree, low threshold to do a carpal tunnel release. Chuck, before we go to volar technique pearls, are you bone grafting on the regular?
No, not bone grafting, almost ever. And I agree with Megan's comments about carpal tunnel. It really is interesting. The block point is really important because I think about that every time I'm in. We block almost everyone, but if I'm doing any type of osteotomy, I think twice about whether to say yes to the block, or I'll do a short acting block, ask for a 6 or 8 hour block. The problem becomes pain control gets really tricky in those patients. So you get pain relief for 6 hours, and then can they catch up and keep up? It's tricky, but I think you have to err on not blocking if there's any concern for postoperative challenges with swelling, which of course there would be here. So Megan, we all know how to do a volar approach, but how do you think about, once you've done your volar approach, what are your steps to, create or recreate the normal anatomy?
Yeah, I think the biggest thing to add that you don't do with the dorsal approach really is you can use the plate as part of your reduction, which is what Chris was alluding to previously. And I think that's important to talk about because sometimes when you're doing these open wedge osteotomies, they become unstable. And then all of a sudden you've made a hard surgery harder because now you have two very unstable components that you're trying to stabilize. And so if you put the plate on and you can get your distal screw holes by putting the plate on, do a couple of drill holes, some K-wires, make sure you're in a parallel with the articular surface. And then you take the plate off and do your osteotomy. You have at least the placement of the plate distally. And that makes at least one component easy. And then you can just realign that with the shaft. So that is a pearl that's, I think, really important to remember of pre-planning for this osteotomy by making sure that you know where your plate is going to go so that you're not having two unstable edges and then all this space that you're trying to fill or not fill, making it harder for yourself.
Yeah, I think that's a really good point. I run into trouble, maybe too strong, but I have to carefully think about the placement of that plate, especially if I'm trying to increase radial inclination at the same time. And so you have to be really precise on how you conceive of where that plate is going. But if you get that right, the case is over, right? You've finished the case.
Yeah, the carpentry on this has to be, really spot on and perfect from the get-go. And I think that your point about, taking a case, that is, taking a segment that's stable but deformed, but then having two very unstable segments can be really frustrating and challenging. So I think pre-drilling on the far side is super helpful.
Yeah,
and what?
Go ahead.
Sorry, I forgot to mention this. Chris, one of the things that I do for that dorsal scarring is I will put a lobster claw on the radial shaft, and then I'll rotate the components away from each other. And then I feel like I can really release that scar tissue dorsally by rotating it. I use that actually with subacute distal radius fractures that show up to my clinic later in the game. So that's another way of not having to make that dorsal approach.
Right, you really got to have that thing completely free dorsally.
Yeah.
And I think the error, and I've learned the hard way, is that you're like, oh, it's probably fine. But I think that, the pronating that distal fragment or moving the shaft too is helpful just to really get to the far side of it and make sure, especially as you're over, just proximal to the sigmoid notch on the ulnar side.
Yeah, it's probably fine that's going through your head as you're doing cases like this is always sort of the kiss of death, especially if your day is going crazy. You just can't let that happen. But I think both your points are really good. So the Orbe technique of pronating the radius out of the way is really great. But you have to make sure your dorsal release is complete, or else you will not correct the angulation that you need to correct. So super, super important. Great. I love that. What other volar thoughts do we need to finalize?
So I don't want to bring up another huge topic as we're trying to wrap up, but I do want to point this out because this is something I've learned and been burned with. I've had intra-articular distal radius malunions, and I'm intrigued to hear what you guys have to say, where I have done personalized jigs. Where they take the CT and they make jigs and you spend all this time planning out your osteotomies. And you think it's going to be really, really easy because you just like make a cut here, you make a cut here, you make a cut here, and you put these little jigs on step 1, 2, 3, 4. And it's almost like paint by colors. You think it's going to be really easy. And then it's not, because you have engineers who are looking at these CTs and making these jigs, but they're not surgeons. And you're starting to realize, oh my gosh, there's a lot of scar tissue, and trying to rotate this component and this component is not as easy as 1, 2, 3. And I've struggled with those cases before because of scar tissue.
We do need to have a separate episode for this because I feel like we just had this conversation.
Sorry,
we just had this conversation in our hand conference earlier this week when Lindley Wall was talking about a materialized case that she did using custom jigs and the challenges of what surgeons think versus engineers, and where the engineers will try to put the plate versus where a surgeon wants to put the plate.
Yeah, It is a really important point. So we have our part two that we're gonna have to do.
Well,
I
before
don't.
we,
Yeah, go
sorry,
ahead.
Chuck, I just had one more question. I think it's pertinent. Is this a standard kind of distal radius fracture rehab for you guys, or are you immobilizing them for longer after this kind of thing? Especially if you've got a wedge and you're not grafting, that kind of thing, or do you just proceed like you normally would?
Megan?
Oh, Chuck, I wanted you to answer that first, but I'll go. It depends on the patient, honestly. It depends on the fracture or the osteotomy and, how strongly I feel like this is going to heal. So, I do think you need to do a little bit of range of motion, some gentle range of motion just to keep them moving because, a lot of these guys and girls are stiff. And so all of a sudden you splint them until they have union and they're even more stiff. So I think it's important that they have the tendons gliding and there is a little bit of motion, but again, this is going to be patient specific.
If you have a good plate, these plates are really strong and the bone is reasonable. Even if you've created an open wedge osteotomy, I think it's okay to start early therapy with splinting between therapy sessions and no crazy therapy. So I do start early. So this has been super fun. Thanks for joining us. This has been great. We definitely
Yeah,
have to
thank
do
you guys.
part two, part three. Keep going.
Oh, wow, you're really
I'm
promising.
trying to I'm just trying to like weasel my way in.
You've succeeded.
It's been
Well, thank
it's been
you.
a joy as always, Megan. Good luck with your upcoming move, and we look forward to having you back either before or after the annual meeting.
Yeah, I'll hopefully see both of you at the meeting
With
Hopefully,
our passports.
yes,
with your
for sure.
passports. Yes. Thank you guys so much. This has been an absolute blast.
Thank you.